Hello there, I'm Tony Meekum. This is topic 11, the ill-defined, ragged, radiopaque, and mixed lesions. So again, have your study guide and chart handy as always. So last year when I taught this, it was shortly after I got back from a trip to Chicago with the ADA. These are some pictures from the ADA headquarters building. Pretty nice views from there. Someone as I was taking this picture says, "Hey, is he your great-grandfather?" G.V. Black, yep. Apparently I look just like him. And so quick orientation, go back to your differential diagnosis chart. There's one box called COME, C-O-M-E is the acronym to help remember this. I should have called it OCOME because there's really two O's. And so I wanted to start with osteomyelitis because that's common and something you're going to see a lot of, something we really need to be able to identify as a dentist. And then I talk about osteosarcoma and chondrosarcoma kind of together because they can look similar. Then we have Ewing sarcoma and metastases. The rest of these we've either covered or we're going to cover Paget's in a future lecture. And so let's start with osteomyelitis, and I'm going to talk about medication-related osteonecrosis of the jaw and osteoradionecrosis in conjunction with that because they look very similar in imaging. So osteomyelitis. Fast review through this inflammation since we've talked about inflammation before, but these are the four cardinal signs of inflammation. So the clinical signs: redness, swelling, heat, pain. Whenever you suspect inflammation, look for these clinical signs. You'll probably see one or more. And then we've talked about this. Acute is rapid onset. It resorbs bone, and so it looks radiolucent, whereas chronic is insidious, meaning it's slow onset, and it forms bone, so it appears more radiopaque. Most osteomyelitis is going to be a mix of both, which is exactly why this topic is opaque or mixed density lesions. And the clinical features may differ a little bit. This is usually more associated with fever, although chronic can be, although more intermittent low-grade fever, and more pronounced pain in acute, or less intense pain with chronic. And this is key for us, me being a radiologist. Bone resorption makes it radiolucent. Bone formation makes chronic more opaque. There are some contributing factors that lead to susceptibility to osteomyelitis. First of all, suppressed immune system. Diabetes is something that can suppress the immune system, medications, certain diseases. So there are some diseases that suppress immune system and also other diseases that relate to decreased vascularity like osteopetrosis, certain types of anemia, AIDS. And there is a lot of different terminology related to osteomyelitis. As a dentist, it is important to recognize these. You know the difference between acute and chronic. Suppurative means what? Creating pus, as does pyogenic. And then subacute is more of an intermediate phase, so think somewhere between acute and chronic. Of course, non-suppurative, Garré's osteomyelitis, we're going to talk about the onion skin appearance. And then this is similar to that, proliferative periostitis, periostitis ossificans. And we'll talk about these. These are a little more rare, but other syndromes related to osteomyelitis, as osteomyelitis is a feature of them. All right, based on what you know, why do you think the mandible is a much more common site than the maxilla for osteomyelitis? Well, the mandible is a harder bone, a much more dense bone. It has less vascularization, and so that makes it more prone to develop infection. And it is more common in male, but this is a fairly common disease. I probably shouldn't have put two greater than signs here because I don't think that that's as big of a difference. Can occur in any age. We've talked about acute versus chronic. And if there's significant bone loss, it can lead to tooth mobility, percussion sensitivity. And as it interacts with the nerve, it could lead to paresthesia, but this is usually more of a malignant feature. Osteomyelitis has to be pretty extensive to affect the nerve. But malignancies, as soon as they start communicating with the nerve, it starts interacting with that nerve and creating pain, paresthesia, strains, maybe those prickling sensations. And so he said much more common in the mandible, rare in the maxilla, and the most common site is the posterior body of the mandible. Usually this is going to be ill-defined, blending. That does vary to some degree. Maybe it'll be more ragged in appearance. As I said, usually it has a mixed stage where there's been some resorption and some sclerosis, and so you have this mixed appearance of radiolucent and radiopaque. On the next slide, we're going to talk more about Sequestra and periosteal reaction, which are features of osteomyelitis. If it spreads to a joint, so in our case, the temporomandibular joint, that can lead to septic arthritis that can start resorbing the surfaces of the mandibular condyle or the articular eminence. Maybe you'll see that periosteal reaction around those joint surfaces. And so depending on how aggressive it is, how long it's allowed to grow, it may progress and resorb through the cortex, and it may progress to the periosteum. So we typically think about the periosteum being lifted by acute inflammatory exudates. And then over time that subsidizes and it leads more to the chronic stage, and that's where the periosteum is stable and it is able to lay down more bone. And then it can do that in cycles. And you start to create this pattern, this periosteal reaction, which is characteristic for osteomyelitis, although not pathognomonic. And so when you have that layered periosteal reaction that runs parallel to the bone, sometimes we call that an onion skin periosteal reaction. That always makes me think of this guy right here. Shrek. Why? If you're familiar with the movie, he says ogres are like onions. And we call this onion skin reaction. So naturally, the way I remember it is Shrek. Whenever I see that periosteal reaction, the first thing you should think of is osteomyelitis. Why? Because onions have layers. Osteomyelitis has layers. This mnemonic kind of has layers. Maybe if you think of that as an extra layer to remember, that's not that helpful. And then the book talks about the hallmark of osteomyelitis is Sequestra. When I read that, I always think of the Hallmark channel. So what's the best way to remember the features of osteomyelitis? Just imagine Shrek in a Hallmark movie. And here's the dialogue between Shrek and Donkey when he tells him why he's like an onion. Not because he stinks, not because he makes you cry, but layers. And that's our big mnemonic. Now showing you some examples of those. Here we have a radiolucent lesion. I would say it looks somewhat well defined, but when you have ragged borders, then you're thinking more along the lines of categories that are similar to ill-defined. So think of your inflammatory, think of your malignancy. This could be malignancy. What I notice is it communicates with the PDL space here, and the PDL space is normal, completely uniform, and there's no evidence of PDL space widening like we talked about in the malignancy lecture. And this one is more ill-defined. Still, the PDL space is mostly intact here, nice and well-defined and uniform. Same with this one. It's just kind of creating this blended appearance. And this is showing that osteomyelitis can form this ill-defined radiolucent with no real evidence of a sclerotic border around it, no real mixed appearance. And so that would be our acute osteomyelitis. And in some cases, this can be difficult to differentiate from malignancy. Versus chronic osteomyelitis, which side has the problem here? Well, we have an extraction socket over here, but mostly this bone appears normal. Maybe there's some sclerotic reaction to these previous teeth that were here. But this one looks way different, right? This mostly sclerotic bone, very radiopaque. Look how well the inferior alveolar canal stands out. And then there's some kind of mixed, ragged radiolucencies internally. And so this is our chronic osteomyelitis. Just like when we're talking about chronic periapical inflammation, sclerosing osteitis, it's when we see more of the chronic stage, that chronic reactive bone to the infection. And then this should make you think of what? The Hallmark channel, right? We have our Sequestra of osteomyelitis. And you saw this before in our Acute lecture, our radiopacities surrounded by radiolucencies. One of those was osteomyelitis sequestrum. And this does have a little bit of an irregular border. It does look well defined. But remember, osteomyelitis can look well defined if somewhat irregular. And this one, we also showed you before, another sequestrum. This one's below the canal, so you probably shouldn't even think odontogenic type of lesions. Here's another example in CTs. Here we have an axial CT, very ragged, mixed appearance, kind of moth-eaten, where you see that irregular appearance, start thinking, okay, maybe it's inflammatory. If not that, it might be malignancy. But we do see these sequestrum in here, so Hallmark channel again. Same thing with this coronal slice, very ragged appearance. We see some periosteal reactions, so here's our Shrek in the Hallmark movie. But those sequestra are what really tells you this is likely to be osteomyelitis. And chronic osteomyelitis is the one that more commonly forms those sequestra. All right, what do we see here? A little tough to tell, but there's a little bit of opacity in this occlusal mandibular film, and it's surrounded by radiolucency, so there's our sequestrum. What about over here? And you've seen this image before. Ragged border, mixed appearance, sclerotic bone around the border, and the sclerotic sequestrum in the middle. So we have the Hallmark sign of osteomyelitis. And what's this right here? Well, Shrek approves. He sees the periosteal reaction. And those two together, it's kind of a slam dunk that you're looking at osteomyelitis. Once again, onion skin reaction, parallel periosteal formation, periosteal calcification at the inferior border of the mandible. In this case, alternating radiolucent radiopaque lines. There's our Shrek appearance, osteomyelitis. And this one's really significant. But if you can appreciate these layers, looks like onion skin. This one really looks like an onion because it's nice and round. And when it's extensive like this, sometimes it gets the term Garré's osteomyelitis. Once again, there's Shrek. So now you're not going to be able to see these and not see Shrek and immediately think osteomyelitis, right? And there are a few other things that do create onion skin periosteal reaction, but the first one that should come to mind is osteomyelitis. This one, just glancing at it, It looks kind of ground glass, kind of expanding like fibrous dysplasia. Teeth may not really be affected, but what's the arrow indicating? Here we have an axial slice. First glance at this, oh, this is the same one as the last case, the same one as that panoramic. It looks a lot like fibrous dysplasia. See that ground glass appearance? The kind of gradual expansion. Only fibrous dysplasia, you'll never see this, where it leaves behind that original cortical bone, and then you have a secondary periosteal reaction. So that's our onion skin appearance. And if you're just focused on kind of the overall appearance of this, you might think fibrous dysplasia, and that's why you really need to look for these signs. On the buccal, you see it as well. And so that's our onion skin appearance, which tells you it's osteomyelitis. Oh, there he is. Good old Shrek. All right, hallmark sign of osteomyelitis. This is a sequestrum, very dense bone. It's sclerotic around it as well, but sequestra tend to become really dense eventually as well. Kind of a moth-eaten, mixed, irregular appearance. So this just looks overall bad. You're thinking inflammatory, malignant, hopefully, if you've got your categories down. And could it be osteomyelitis? We'll look for those hallmark signs. And here's our sequestrum, so osteomyelitis. Here we see a panoramic image. There was an inflammatory lesion around this tooth, and there's a fistula, draining purulence, going. A lot of times that tends to extend inferiorly and communicate through the inferior border of the mandible. And that's what we're seeing here. This is one of the advantages of CT, is now we can see it in the axial slice. And what are we seeing here? Well, we're seeing the fistula going through the buccal cortex as well. But look at that periosteal reaction. So showing you that there's this localized inflammatory reaction. Maybe it's a localized osteomyelitis, but there's some bone reaction going on there, which is a reaction to the infection. All right, and these are other conditions that may create chronic osteomyelitis. First one is chronic recurrent multifocal osteomyelitis. That tends to occur more, though, in long bones of children, which causes a lot of pain, non-purulent. And then we have our SAPHO, synovitis, acne pustulosis, hyperostosis, and osteitis, which occurs in adults. And these patients have pustule-like lesions on the palms of their hands or in other places. And these are difficult to treat, hard to treat just with antibiotic. These are cases that are going to require some medical intervention. But as far as imaging and what you might see as a dentist, it'll be findings similar to chronic osteomyelitis. Tough to get a culture from it, tough to treat, as I said. Some of these patients you got to be really careful about. Osteomyelitis can be a serious condition, especially when it's long-term and it's chronic and it's extensive. Really difficult to treat and probably beyond your scope if you're just a general dentist. This shows a couple images of the SAPHO syndrome, where they have that very sclerotic bone. It kind of looks like fibrous dysplasia. I don't really see periosteal reaction. Nothing about that image really shouts to me osteomyelitis, but knowing they have this condition, they have the pustules on the palm of their hands. This is our SAPHO syndrome. And then these are our CT images of that same case. Just kind of a granular mixed appearance. You might describe some of it as irregular. And then here in the CT, now we do see a sign of what? This was our hallmark sign, our sequestrum, showing you that it is a form of osteomyelitis. All right, and then this differential for osteomyelitis, this is pretty much the rest of the lecture in miniature. So acute can look malignant, which we already covered. Fibrous dysplasia, there's not going to be a periosteal reaction, usually not quite as patchy and what I just described as nasty looking when it's really patchy and irregular, where it could be either osteomyelitis or a malignancy. You usually don't see that with fibrous dysplasia. Paget disease, think of it usually occurring in the entire mandible. And again, no periosteal reaction. Osteosarcoma can look somewhat familiar, so when we get to that, look for more signs of malignancy. Look for its extent into the PDL space and causing that irregular PDL space widening. That's a big one. Osteosarcoma, what you're going to remember from that is the sun ray appearance, which doesn't happen in osteomyelitis. So sequestra, periosteal reaction, or what really pull you back to osteomyelitis, just remember Shrek in a Hallmark movie. And then management for acute, remove the source. Either of these are going to require antibiotics, in some cases incision and drainage. Chronic is much harder to treat. Anti-inflammatories may help, and in some cases maybe even better than antibiotics. So in most cases, I'd recommend getting additional help from medical providers as well. All right, now we're going to go on to the two lookalikes, meaning they look just like osteomyelitis, and the real thing that differentiates these is the patient history. First of all, radiation-induced changes to the jaws, which is a precursor to osteoradionecrosis. So radiation kills everything, basically. In high enough doses as we do radiation treatment for an existing malignancy, it's going to kill the bone cells, also damage small vessels, leaving hypovascular, hypoxic bone that can't really heal. And that can tip the osteoblast, osteoclast scale in either direction. So you may have resorption or sclerosis. And with that hypovascularity, you're going to have hypoxic bone, which reduces healing potential. So we'll talk about post-radiation changes, which can look nasty. It can look really mixed and sclerotic and destructive versus true osteoradionecrosis, which is where there's actual bone cell death. But imaging, it's going to look really similar to osteomyelitis or some other mixed malignancy. Usually ill-defined, sometimes well-defined but irregular, maybe moth-eaten. This can cause irregular PDL space widening, so I typically reserve that sign for malignancies. But if they have a history of radiation treatment, it could just be this radiation changes to the bone. So some examples of that. This is pre and post radiation treatment. See how the PDL spaces look nice and uniform, normal bone. And then it just has this mixed appearance. If I just saw this image, my mind immediately would go to osteosarcoma. Just this kind of mixed moth-eaten appearance. The widening of the PDL space, it just looks bad, looks very foreboding. Same with over here, lucency following the roots of the teeth like that. That's kind of classic for osteosarcoma, but it could be an inflammatory thing, right? And so you're thinking maybe osteomyelitis. Knowing the history of radiation treatment, then yeah, probably just radiation changes to the jaw, but that's going to have to be monitored really closely, especially if the previous tumor was a bone lesion, there might be recurrence there. This again is pre and post. In the mandible here, it's a little more subtle changes, but you can see the bone looks a little more sclerotic, maybe a little bit of that PDL space widening, just some subtle hints. Oh, right here especially, there's some PDL space widening, some hints of those post-radiation changes. And then this one looks really bad. Axial slice through the maxilla. It's really destroyed the posterior border of the maxilla, caused some thickening, sclerosis, and moth-eaten appearance of the borders of the sinus. Not knowing they had a history of radiation treatment, again, this looks like malignancy, the way it's so just irregular and destructive. Then same thing in the mandible, in the axial slice here. Mixture of sclerosis and resorption, irregular, just an overall bad appearance. All right, here's the punchline of this slide. It's difficult to distinguish from osteomyelitis, and so history is key. That's the whole lesson. So you see things like this, if you know they have a history of a head or neck tumor, malignancy, then ask if they had radiation therapy, and then that could explain some of these changes you might see. But let's get to true osteoradionecrosis. And so if those radiation-induced damage is bad enough that it actually starts to cause necrosis, that's when we're talking about osteoradionecrosis. Similar radiographic findings, so you see all those similar changes. But radiographically, what actually means necrosis is when you see a sequestrum. So like we've talked about. Clinically, the diagnosis is when you see exposed bone, and it's been exposed for over 3 months, at least 3 months after the radiation therapy. They can be susceptible to pathologic fractures, and this may not be painful. That bone could just be so necrotic that it's destroyed the nerve tissues as well, and so they might not have a lot of symptoms. And pus is variable as well, so is swelling. And so imaging, like I said before, just the same as for osteomyelitis and radiation-induced changes, I would say as well medication related, which we're going to cover next. However, if you identify Sequestra, then you can surmise that it's likely osteoradionecrosis in the case of previous radiation therapy. All right, so what is it here that tells us it's osteoradionecrosis and not just radiation-induced changes? Here the resorption is really prevalent. In this one it's more mixed, but what do we see right there? There's your hallmark sign. In the case of previous radiation therapy, that is more of a hallmark sign then of osteoradionecrosis. So again, just highlighting that concept, it's the history of radiation treatment that tells you. And then the bony sequestra is what tells you, yeah, it's more radionecrosis at this point rather than just radiation-induced changes. Might be really difficult to distinguish from a malignant neoplasm. And so if you see this, patient might need further workup. If it's been a while since the radiation therapy, especially if things are starting to develop, probably going to require a referral back to their physician. And so treatment is unsatisfactory, and this is a board question, so take note of it. You prevent osteoradionecrosis by removing compromised teeth before radiation therapy. That's why we do that. You want to get any remotely compromised teeth removed before radiation therapy. That's assuming, radiation therapy to the head or neck that's going to penetrate through the bone, either the maxilla or the mandible.